Hello, everyone, and welcome to another lecture for interventional radiology. Today, we're going to talk about intravascular foreign body retrieval and informed consent. All right, so here we go. Roadmap today. We're going to talk about the foreign body retrieval, what steps are needed to do that, and of course, the ever popular informed consent. We need informed consent on everything, and we haven't really talked about that before in detail. So today we're going to do a little bit more of a deep dive into informed consent, the history, what's required, policies, federal regulations, state regulations. So there's quite a few things to know about informed consent. All right, so first of all, our percutaneous intravascular foreign body retrieval in interventional radiology is considered the gold standard for retrieving foreign bodies. The success rate is anywhere from 91 to 100%. And the only failures will be if you have a possible perforation if you continue. So you have to go through the surgical route. All right. So what are some indications and contraindications for removing an intravascular foreign body? Reasons why you want to do it. Maybe you have a fractured guide wire. You have a defective piece of equipment that was put in for some reason and it fractured. So you have this length of guide wire up in the body somewhere. You'll need to go in and get that back out. A catheter might malfunction. So you have a piece of the catheter that is separated from the main catheter and now is a foreign body. You have to get that out. Pacemaker wires sometimes will give out, especially on patients that have like twirler's syndrome, which is rare, but it can happen, where they fidget with everything. So if they have long hair, they might be fidgeting with their hair. If they have a pacemaker, it might go in and fidget with the pacemaker and the leads might break. Endovascular devices, we might want to get those back. Embolization coils might be deployed and moved to the wrong location. You need to get those into the right place so you're not embolizing the wrong area. IVC, inferior vena cava filters, and stents that are malpositioned, whether it be that they moved later or if they were deployed accidentally in the wrong spot. All right, so those are some great indications of why you want to go in and retrieve something. Contraindications, of course, would be if you get in there and you look and see that there is excessive thrombus on that area. And if you take that foreign body out, it will embolize and you will be creating a worse situation than what already exists. All right, so that's not a good thing to do. So we want to avoid the situation. So that's contraindication. An firmly embedded foreign body. So if you tug on it and try to pull it, it's embedded into the vascular wall already. And if you continue to pull on it, you might perforate. Foreign body, if the foreign body is already perforated in a vessel, that is a reason for vascular surgery, not a foreign body retrieval. You will make the hole larger by trying to remove the foreign body, and then you have a worse situation than you already had. All right, and of course, the other one is lab values. If you have a if you have a coagulation issue with it not being able to coagulate, and if you go in, you have an open wound that won't heal. So you no longer have hemostasis. So that's not a good reason to go in. All right. So procedural prep. There's two types of procedures that you will run into. A planned approach, say, for example, a pacemaker wire that's broken. and you need to go in and take it out, or some other device that has a broken lead. And there are situations where you are doing a procedure, and during that procedure, you accidentally create a foreign body. So then you have to stop that procedure that you had planned to do, and now retrieve that foreign body so you don't have the complications of embolism and potential occlusion of things you do not want to have occluded. All right, so those are our two main categories. Let's take a look first at our planned procedural prep. So first of all, when you're planning anything, you want to take a look at your prior imaging and take a look at any specifics that might be a clue to what you're going to do for your procedure. So for example, this one, if you have any imaging modalities that show the location of the foreign body, you want to focus on those so you can plan the procedure to get it out. Of course, you need appropriate equipment. So your devices to get the whatever foreign body it is out. So you could have a implants, a gooseneck, you could have a snare, you could have hoops that you can make on site. If you don't have one that's specifically designed, you have a retrieval basket. You can also use gripping forceps and or pigtail catheter to help loop whatever foreign body is there to capture it so you can grab it with one of the other devices. Of course, you always need to have lab values whenever you're doing an invasive procedure to make sure that they will have no coagulation issues, whether it be too coagulative or if it is not coagulative enough. So you need to look at those values, see if they're within range. And of course, lastly, your signed consent form, which we're going to talk about in pretty good detail here today. All right, so that's the first one. Second situation is you are doing a procedure. You have the signed consent form for an embolism, embolization, and you're going to be deploying coils, right? So you get in and you're doing that procedure, and a coil escapes and is now in danger of occluding something you don't want to be occluded. So you need to now go and retrieve that. You didn't really have the patient consent to a foreign body retrieval. So can you or can you not do the exam? So first of all, intraprocedural, you already know where the foreign body is located because you just saw it become a foreign body from what you were doing. You don't need prior studies because you're already localized on it. You don't need lab work because that's already been done. So now what you need to do is find the appropriate tools to get whatever is dislodged and is a foreign body now instead of a therapeutic tool. You need to get that back. So you need to get the appropriate tools to retrieve it. So catheter, sheath, forceps, any of those other devices we just talked about. Now, consent. You don't have a written consent and the patient doesn't have foreknowledge of what you are going to be doing. Can you do it? Well, let's take a look at informed consent rules and regulations before we go on with the rest of the procedure. All right, so there are federal guidelines, there are state guidelines, and then each hospital should have a policy on informed consent, when it's done, who can do it, et cetera. So we're going to talk about each one of those. First of all, a little bit of history. So back in 1945, at the end of World War II, it became apparent that the National Socialists, the German workers, the Nazi Party, were doing human experimentation on their captives without their consent. So during the Nuremberg trials in 1945 through 1947, we created the Nuremberg Code. Specifically, it was for, at that time, research-based. So you couldn't do any research without informed consent. Later down the timeline, we extended that to invasive procedures. They should have the same criterion, right? And the Nuremberg Code is an international agreement or law that has multiple nations that have agreed to do the exact same thing. So what is informed consent? First of all, the person has to have the cognitive ability to understand what you are telling them and to make decisions. So they have to have mental awareness. Second, they have to have legal age. If they are a minor, their legal guardian or parent will have to sign the consent form for the child. Okay, and there are specific rules for when a child in a research study, when a child goes from a child participant in a research study to an adult in that same research study. So it's not really important for this discussion unless you are going to go into research, and then you need to know those laws. And there's various resources that you can take a look at that time when you need to know that information specifically. So mental awareness, legal age, they have to have the information given to them so that they can make an intelligent decision. The patient has to be participating in the conversation. You can't just talk to them and say, here, sign this. They have to acknowledge and participate in that planning. A lot of times they'll just say yes, but they have to be given an opportunity to ask questions and participate and have a two-way conversation, as opposed to, here, I'm talking to you, sign this, let's go. Okay. And then a legal designatee. All right. So it's someone that if the person is not cognitively aware and cannot make their own decisions or are underage, they need to have someone be able to be assigned to make that informed decision on the patient's behalf. All right. So those are the basic requirements for informed consent. All right, so legal requirements. This is the federal regulations. So this is a federal mandate. And then each state can have their own. We'll take a look at that too. So there's a lot of elements. I'm going to be skipping some of them because they'll be devised by your legal team, and it's going to be on the form already. So you only have to do is make sure the name of the patient is on the form. So it can be paper or electronic. Okay, so make sure the patient's name is on there so we know who we're going to be operating on. Numbers 2 and 3 is just if you're sharing information, who can you disclose that to, and it should be defined. That's more for research. Section 4, again, this is about disclosure and for research. So these don't apply for most of our situations when we're in interventional radiology, unless we're in a middle of a research situation, and then they apply. So we're going to skip over those parts. The names of the individual or entity participants. So who is taking place, which is the physician and the team members, they need to be, according to this, on the document so that at least the physician is noted on there. Usually the rest of the participants can be listed in the rest of the documentation, but that needs to be documented somewhere. All right. B5 and 6, we're going to skip over again because that's more for the research and disclosure of information to other parties. So that will be built into the consent form. So we don't necessarily have to worry about that. We do have to worry about the date of the event, okay? And when it will expire. I don't know if some of this writing is underneath my picture here, but when will the consent expire? Can the operation take place 31 days later, 41 days later? Can it take place only 10 days later? That should be noted on there. Usually they are obtained the same day of the surgery. Sometimes the doctor will have the informed consent done in their office a couple of days before, and we'll take a look at what has to happen with that. Okay, signature of the patient. All right, so if the patient is a minor, or is unable to sign for themselves, you have to have a legal guardian, a parent, or a legal representation that is in the advance directive, et cetera. All right, so they are able to sign because it's documented that they are able to sign. All right, and that's through your policy in the hospital. Okay, and of course, it has to be signed and dated. All right, so we talked about this on such and such a date, and then we're going to do the procedure either that day or some other day. Okay, now last part, section B. It can't be any of these. It can't have an expired date that was up here. Okay, if you try to do it after the expiration date, it is no longer valid. So you have to get another informed consent. If the patient has gone from cognitive to an altered level of consciousness in the interim, the patient can now no longer sign. So you have to find their legal representative to sign for them and give them the same information you would give the patient so that their stand-in can make the informed decision for the person that they are representing. Okay, if it fails to conform to any of the requirements set forth in the paragraph up here, all these stipulations above, it is known to be revoked. So the patient said, yes, I'll do it, and then verbally said, no, I don't want to do it. That is no longer a valid consent. The patient has revoked their permission for you to do whatever test or procedure you had consent for, and it is no longer valid then. So you have a couple options at that point, which we'll talk about when we're doing our case study in just a moment. Is known through reasonable diligence could be known. So you could know it, or you should have known it and looked into it. Okay, so the law doesn't care if you didn't know and it was wrong, you should have known. Okay, that's the legal standard. So ignorance is not bliss here. Ignorance is guilty. So if you knew it or if you didn't know it, but you could have researched to find it out, by the individual or entity holding the records to be material false. So if you have a false statement on your consent, saying you're going to do one procedure and then do a different one during the procedure, that makes that informed consent non-valid. It's now a false consent, and you have committed assault and battery on that patient by performing that exam. So there are legal repercussions for that decision. So CMS also is federal, so they have their standards that they want to. The right to make informed decisions means that the patient or patient's representative, like we talked about earlier, is given the information needed in order to make an informed decision regarding their care. Okay, so the patient either might wish to delegate that decision to someone else, or they might be forced to because of altered level of consciousness and lack of decision-making power, etc. All right, and that's covered by state law. So if you are in California, you need to know California's law. If you're in a different state, you need to know what the law says. And it's easily enough discoverable. Just look it up on a search engine, say California state law in informed consent. And often it will be tied to the Attorney General's site. That's where the California law is. It's right. I found. Okay, so make sure you know what your state law is, because I'm not really covering it very much here because there's so much data that it would make this lecture extremely long. All right, so look up your state law. Okay, hospital must respect the patient's wishes and follow that process. Now, that doesn't mean that they can say, well, I think that you're giving me an X-ray, but I want an MRI. They can't demand things that are medically unnecessary. So the hospital provider can't say, well, we have to do whatever you say. That's not what this law is saying. It's saying that if it is within medical standards and the person says they want to have this test, that you have to look at it. But if it's medically not unnecessary, if it's medically unnecessary, you don't have to do it. Okay. In some cases, the patient might be unconscious or otherwise incapacitated. So if you dislodge a foreign body in the middle of a procedure, the patient might be under anesthesia. If they're under anesthesia, they're unconscious, and or if they're awake enough, they still have mind-altering medication on board, so they are unable to give consent. So you now need to look for your backup consent. Do they have an advance directive? Do they have a power of attorney? Do they have a patient representative, a relative? Whoever is legally assigned to make medical decisions for this person must now be consulted if they are available. Now, if they are unavailable, there are certain things that can go under. So the patient consented to an invasive procedure to correct whatever pathology there is. So the reasonable person expectation is a law that states that what would a reasonable person choose to do in this case where they are unable to make a decision and you have to make the decision for them because you don't have any of that backup. No advance directive, no power of attorney, no patient representative or relative. So if you don't have any of those, you have to make the decision for the patient. What would a reasonable person do? So if a reasonable person consented to an invasive procedure to improve the quality of their life, and you have made an accident or mistake during the procedure and now have a foreign body within that patient, a reasonable person would say, yes, please take that foreign body out and make sure I don't have something else go wrong with me. So that's the reasonable person standard. So in the cases of emergency, we can invoke that if we cannot find any other person to make that or to agree with us, because it is medically necessary. Okay. All right, and I'm sure you can take a look at the rest of this verbiage here. I did copy the whole thing. I'm not going to read the whole thing word for word because I want you awake and being able to, pay attention as to me putting you to sleep. All right. The right to make informed consent decision regarding care presumes that the patient has been provided information about his health status, the diagnosis and prognosis. The patient has to participate in that discussion. The patient has the right to agree to the treatment plan. The patient has the right to ask questions about alternatives, and they have the right to refuse the exam. Once they refuse, you are done. Okay. You need to give them all the information that they need to make an informed decision, including risks and benefits. That's included in adequate information. And they have to be cognizant enough to understand what you are telling them. So that means also that the information you are giving them has to be in a language that they understand. Okay, so you can't tell someone in English any information and expect someone that only speaks Spanish to have any information given to them or any other language that you might be dealing with in, there's pockets of people that speak Korean and Vietnamese and Spanish and any other language you can think of. So if your normal patient load has a certain percentage of the population speaks a certain language, you have to provide forms up front in that language. Or if not, you have to have a certified medical interpreter interpret the forms and the conversation into the language that the person will understand so that they can participate in the informed consent. If you just say a whole bunch of gibberish to someone and they don't understand it, that isn't informed consent, of course. All right. You have to have the consent form signed and executed. dated before the surgery. Now, the exception is emergencies. So you have, for example, a motor vehicle accident, the patient's rushed to the ER, they need to have open surgery, they whisk them off to surgery. They're not going to try to wake the person up to have them sign or take time to find the relatives. They're going to go ahead with the surgery. And again, the Good Samaritan law and the reasonable person standard covers us for those emergency situations. Okay, primary purpose of the informed consent is that to ensure that the patient or their legal representative is provided information needed to make sure that they have the information they need to make that informed consent, and that's before surgery. So not a very good practice is to have your patient wheeled into the operating room, have them sign a consent, and then move right over into the table. That doesn't leave enough time for discussion. It doesn't, and it could be considered that you are trying to pressure the patient into the surgery by putting them into the room and everyone's waiting for them. So they might feel obliged to sign the consent. I know it might sound silly, but there are, especially generational situations where a certain generation will do whatever their doctor says they should do, or lean in that direction. Not everybody, of course. So you want to have the consent form signed outside of the surgery room, preferably in the pre-op or before, so that they can't come back and say that you coerced them into having the exam. Okay. The patient needs to know the risks. So we got the patient and their representative. They need to get the information of risks and benefits. They need to know the general incidence of that risk or benefit. They need to sign the consent form. And we're covered in case of emergency to go ahead with a life-saving operation or interventional radiology procedure because of the laws that allow us to use the reasonable person standard. Okay, so a case study. I know of a institution that had a patient, an elderly patient, been married for 5 or more decades, and they needed to have a interventional procedure done. The patient was wheeled to the study room or the operating room door, and the interventionalist had a conversation with the patient and the patient's wife. So the patient said, "Doctor, I am allergic to iodine. I can't have it. The last time I had it, I almost died." The physician said, "Well, we really need to do this operation or this procedure because if you don't, your life is in danger. We need to do this now." The patient said, "No, doctor, I'm deadly allergic. I almost died last time." So the physician said, "Well, we will have anesthesia standing by at the head of the bed. And if anything happens, they will intubate you and we shouldn't have a problem." The patient said no. The doctor turned to the patient's wife and said, "You need to convince him to have this procedure done." And they left. So the wife spent some time convincing her husband to have the test because the doctor said it was needed. The patient finally consents. The physician comes back. They put the patient on the table. They get access, and the physician does a test injection of iodine. The patient instantly had a severe reaction, bronchospasms, laryngeal, and the bronchospasms, and the airway closed. The anesthesiologist that was at the head of the bed took more than 10 minutes to be able to get past that closure to provide oxygen to the lungs. During that time, the patient lost function of their brain. So they went to the recovery floor and they did tests for brain activity, and the patient was brain dead. So a few days later, they pulled the plug on the patient and the patient died. All right, so I'm going to let you pause the video after I explain the instructions here. So what went wrong with that situation? How many violations of informed consent occurred? All right, so go ahead and pause and think about your answer. And when you have come up with your answer, go ahead and resume the video. Okay, so in this case study, there were several things that went wrong. So in the participation of the conversation of the informed consent, the patient informed the physician that they were deadly ill when they received their last iodine injection, contrast media. The physician ignored that. The physician, instead of taking no for an answer and coming up with an alternative plan, continued to coerce the patient and pressure the patient to do the exam. Once the patient says no, you can only maybe ask them one more time if they are sure. And if they continue to say no, you are now done. The physician would then have to think of an alternative solution to fix whatever was ailing the patient. If you spend an excessive amount of time trying to talk a patient into the consent, you might finally get in consent, but is it valid? If you coerced the patient into signing it, it is no longer valid. So any negative outcome that comes out from that, and even if it is a negative outcome, if you did everything right, you still did it under duress and the consent form was still invalid. So regardless of if you have a consent form that's under duress, if you have a good outcome or a bad outcome, it's still an invalid procedure because you coerced them into doing it. So the doctor tried to coerce the patient. Then worse yet, he made the patient's wife coerce the patient. So imagine what the wife feels after losing her husband, and she was the one that helped the physician kill her husband by talking him into it. So you never want to put a family member under the same type of duress and coercion efforts that you did a patient, because that, yet again, is an invalid method of doing an informed consent. Okay, so then, of course, the patient died, the worst negative outcome possible. So in that situation, if went to court, it was settled out of court, and it's a blank check with lots and lots of zeros. So in the millions, I believe, if the case study, if I remember correctly, because that person needlessly died because you ignored their input into the informed consent process. All right, so that's the result of that case study. Never ever try to talk someone into something. Informed consent. So this is the policy that CMS wants you to have. So the management will go through and make this policy, and then you just have to read and follow it. So the policy says who can obtain the patient's informed consent. Usually it's the physician is doing the consenting. You can witness or you can hand the form to the patient and have them sign it, as long as the physician is the one that did the informed consent under most policies. Right? That might vary. Take a look at your policy to make sure that you're following your specific hospital policy, because if anything goes to court, that's what they're going to look at first. Did you follow your own policy? Then did you follow state laws? Did you follow federal laws? So you have to have all three of those in place to be victorious in a lawsuit. And the best thing is to never be put in a place where you need to go to court. You want to avoid court because that's the best patient care possible, is you're listening to the consent, they participated, and they have the mental capacity to do so, they're legally able to do so, and you're listening. If they say, I want to do something else, then you listen to that, and the physician will make that clinical decision. All right, so what procedures you are doing? So we usually put in a long list of the procedures to make sure that we're covering, selective veins versus non-specific vein. So you have what procedure you're going to be doing, the circumstances under which the surgery is considered an emergency. So if it is an emergency, then you need to document that, okay? And this policy will cover you in those situations where you say, well, it was a life-threatening event and we didn't have anyone readily available to consent. And if we had waited, the patient would have had a large negative outcome. That's all going to be decided on and delineated in your hospital policy. Circumstances when the patient's representative rather than the patient may give informed consent. So that should be delineated in that policy. Well, okay, the patient's already under because of this other procedure we're doing. Who can take and give informed consent then, right? So that's all delineated, all defined for you. You just have to follow the policy, okay? Content of the informed consent form and instructions for completing it should be in the policy. So everything's clear and everyone does the same actions so that we have consistency of care across the spectrum of whatever patient we are doing. A process used to obtain informed consent, including how informed consent is to be documented in the medical record. That should be in your policy for the hospital. Mechanisms that ensure that the informed consent is properly executed. That means signed and dated and witnessed, and is in the patient's medical record prior to the surgery. So you have to say, okay, before our universal timeout, we have to check to make sure that the informed consent is signed and is in the medical record. We say, okay, yes, it is, then you can proceed. Okay. If the informed consent process and informed consent form are obtained outside the hospital, for example, that doctor's office that we talked about earlier, how is that going to be properly authenticated and put into the medical record? And that should be defined within your hospital surgical informed consent policy, which also includes us in interventional radiology. All right, so now we get to switch gears and go back to the procedure. Now that we know that it is an emergency, we don't want to have any negative effects from this foreign body that's floating around in our patient. So we're going to go ahead and go straight into the foreign body removal, because we know that a reasonable person would expect to have function to their limb and not have an occluded vascular tree when they wake up, right? So you're going to go ahead and retrieve that under the emergency use clause. All right, so if you are already in the procedure, you've already prepped and draped the patient, but you might have to have access in another area. So then you prep and drape that area if needed, or use the one that you're already using. All right, so of course, vascular access, the physician needs to choose if they're going to go through the jugular or if they're going to go through the groin, whether it be femoral artery or vein. Okay, so they make that choice of what best approach to retrieve this foreign body. Okay, procedure. So there's three types. There's a foreign body with a free end, which we'll talk about, a foreign body without a free end to lasso or grab. And then we're going to also talk about stent repositioning and or retrieval. All right, so the free end. So there's, this one's used the most, okay? So first of all, you take the Amplatz gooseneck. It looks like a lasso, and it is a 90-degree turn here from your catheter. Okay, so you have various sizes, as this demonstrates. So from 5 to 35 millimeters is the standard, or you have a micro set where you go from 2 to 7. So it just depends on what size the foreign body you are going to be trying to retrieve and what size vessel it is in, so that the gooseneck can fit through the lumen. Let's take a look here. Yeah, so you want to make sure that the gooseneck can fit through the lumen size, right? You don't want it to be too big, then it won't work. All right, so you get a sizable sheath. So the sheath has to be able to hold both the foreign body and the retrieval device. So when you pull it out, it doesn't get stuck on the vascular wall. All right, so then inside of the sheath, you have a guiding catheter and you have a retrieval device. All right, so if we're using, get over my pen here, there it is. So if you have a device that's in there and it's stuck to the wall here, not very hard. I mean, it's just touching the wall and it is coming out this way. You have now a free end to get to. So you take your lasso or the gooseneck and you wrap it around there and then you pull so it tightens up like a noose, and then you can pull it back into your sheath and then pull it out of the body. Okay, so that's a very normal way to do it. So if the gooseneck doesn't work, you can also do the basket here, the retrieval basket. So you come up to the device and it has a free end and you entangle it in this basket. When you pull back on the basket, these wires go inward and grasp this. And then again, you go through and pull it through the sheath, pull it through and out of the body. Okay. So that is your dominant basket or your amplat's gooseneck with a free end. All right, so a foreign body without a free end. So you go in and it is over the entire width of the lumen. Okay, so it doesn't have a free end. Sorry. All right. Okay, so it doesn't have a free end there. Excuse me, scribbling. All right, so what you do is you get either your pigtail catheter up here, right? So you get your pig catheter and you loop it over and then you pull downward. And hopefully this will now make it up here. It will free up that area. So now you can go in and use your implants or your basket and catch it that way. So what you do if you don't have a free end, you make a free end and then follow that procedure that we just talked about. So there's multiple ways to do it. You can have a reversed curve catheter. You can have a tip deflecting catheter like this one. Okay, so normally it's up, it's straight, but you pull on a device at the bottom and it can curve. Sometimes it curves in one direction, sometimes it can curve in two directions. So bidirectional guided, right? So it just depends on what type you need to use. And they come in different lengths too, or diameters rather. Okay, so over here, so it could be a short one, or it could be longer, or it could be it depends on what type of curl you need to have. Okay, so they come in different sizes, lengths, and diameters of flexion. This is an interesting diagram. This is from a patent for one of these steerable ones. So if you pull on, there's a device down there that if you rotate around in that direction, it pulls on this, it's anchored at the top. And the more it pulls it, it will pull it down in the direction that you need to do, over like this. Okay, so the more you pull, the more it flexes down to a curl that you need. So you loop that curl over top of your device that you want to retrieve and yank it down, and that will let one end be free and the other end still sort of anchored to wherever it is. So then you can go in and loop it and pull out that device is a foreign body. And lastly, you can have these flexible grasping forceps. At the end, there's a little a tip, right? See, so it comes up and tips. So when you pull back on it, that forces these wires to come to the center and grasp whatever is in the center. It will come up and grasp it on the top there. Okay, and hopefully that will give you enough purchase to grasp it off and create a free end. And you can go in and use your amplats and your basket to loop it in and pull it into your sheath. Okay, so those are the two ways for a foreign body with a free end and a foreign body without a free end. Next, stent repositioning and or retrieval. So you're in doing a angioplasty and you are deploying your stent, but you deploy it in the wrong area. So it's here and you need it to be up here. So there's multiple things you can do depending on what type of stent it is. If it is a self-expanding stent, you will try to get in and loop it with maybe the grasping forceps, or you go in with your lasso or the loop, the gooseneck, and try to compress it down and pull it into the sheath. If it is a balloon extended, so you still have the wire inside, so you'll want to take your wire and extend it past the area of where the stent is, right? So now your balloon is up here. So once you inflate your balloon here and you pull backwards, that will take your stent and move it, hopefully to where you want it. Or at least you can take it completely out if you can put it into the oversized sheath. You can pull it out of the body and then deploy a brand new one, hopefully in the right place this time. Okay, so that means you keep the wire through the stent at all times while you're doing the procedure, deploy the balloon to manipulate the location, and you can use a snare if you have a free end, if it is a compressible stent, right? So if you can go in there and recompress that down as opposed to having the memory expand, if you can send it back down, you can pull it back into the sheath and then either redeploy it or take it out and redeploy a fresh one. All right, so that is your stent removal or retrieval, repositioning. Okay, results. Success, like I said at the very beginning, 91 to 100%. And if it failed, it was because that it was embedded too much into the vessel wall, or there was a risk of perforation if you pulled on it too much. So you can't do that. So you have to go into a surgical route to get that done. Complications, distal embolization. So if the foreign body goes to an area you can't reach, it might occlude that area, whatever area of the body you were working on. So there will be a varying degree of complications from whatever gets embolized and occluded. You can perforate the vessel. So if you perforate the vessel, we'll talk about what to do if that happens in just a moment. Thromboembolization, and for intracardiac, consider getting your cardiac people involved. You can get arrhythmias. You can have valve damage if there's a foreign body stuck within there and you try to pull it out. You can get cardiac tamponade, which can turn into a lethal arrhythmia, and the person can die. So intracardiac, you call the cardiac team and see when they can take the patient sooner rather than later. Management. So if you perforate a vessel, so you can inflate an occlusionary balloon to stop the flow of blood, then you get a stent that's covered that will cover the perforation and deploy it in that area so that the perforation no longer is perforated, it is now covered, and the patient will not bleed out, right? Okay, it won't extravasate into the local tissues of that area. And of course, depending on the vessel, the flow, and the pressure, it can be quite severe. So you want to make sure that you follow those procedures. An occlusionary balloon and a stent that is fully covered, as opposed to a metal mesh that we saw back here, right? So the covered one would have a full cover on the outside. All right, surgical cut down if needed. I was involved with a procedure that the stent almost fell off the balloon. So it was, the stent was out here and the balloon was here. So if you tried to pull the catheter back, it would dislodge. So it never became a completely foreign body. It was still attached to our equipment, but if we did anything wrong, that would become an embolization event. So we finally took a urology basket and fed it through, and we brought it up and we captured the stent that was almost falling off, and we pulled both catheters back down to the groin. Now the problem is we didn't have an oversized stent to sheath. We didn't have an oversized sheath to get it out. So now we have two catheters and a bird cage that was out, right? And a device that was stuck in it. So we had this big wad of material at the end. Let's see, so we had the balloon and the stent, and then we had that cage here and that catheter. So we had this huge wad of stuff, and the hole that we had in the patient was, the lumen was much smaller. So we had to take that person, once we retrieved that, we got it to the exits point. We then took the patient to surgery, and surgery took over. They did a surgical cut down, got into there. They opened up the vessel a little bit more and got all our equipment out, and then surgically repaired the opening and surgically sutured the wound from outside. So that was a several hour case, because we had to get devices that we normally didn't have. And we had to, the book talks about homemaking devices. We had to use a urology basket in order to get the vascular stent out of the patient. So it was a little bit longer, but the patient didn't have an embolism. So they did have a larger area in their groin that they had to recover from, but they didn't have an occlusive event in order to stop whatever blood flow that might have occluded. So all in all, it was a good procedure, because we didn't have a large negative outcome. All right, so anyway, all right, that's the cut down. Anticoagulation, make sure that you have them in the right state of coagulation to prevent any thromboembolism if it occurs, right? If you're in there and you knock off some plaque, you have some anticoagulant on board, and hopefully that plaque will, whatever components there are, dissolve enough so that it doesn't have a negative outcome. All right. And of course, cardiology. So if you have something in the intracardiac area that you need to have taken out, consult them. And of course, for the other one, you need to have backup call for vascular surgery. For example, our case, we called in the vascular team to take over once we retrieved it enough that it was safe to move the patient. And we then moved the patient to the OR, and they were able to continue there. So interesting case for me. All right, so further reading, if you wanted to read anything about what we talked about, there are lots of information. You can get informed consents from the Department of Health and Services. The Nuremberg Code has a lot of information on basic rights. Also some abuses that have taken place, like the government taking people and involving them in medical research without their consent in the military. And here's some more where I got the information for this lecture. And here's where I got the images from. And that is it for today. So I hope that you had a informative time, and leave some comments if you'd like.